Typically, when somebody is diagnosed with breast cancer, one of the first things we want to do is find out how big it is and how extensive it is. And one of the first things we'll do is order an MRI. An MRI is a good way to look at the breasts to see if the tumor is bigger than we think it is, or if it may be in more than one part of that breast, or even in the other breast. It's a very sensitive study, and it's one that we usually do right off the start once somebody's diagnosed with breast cancer. It can give us an idea whether or not the patient is a candidate for a lumpectomy, or whether she might need to have a mastectomy or chemotherapy up front. The other thing that's very important is kind of a multi-modality approach. We use a multidisciplinary approach where we involve medical oncologists. Every patient needs to see a medical oncologist. And if they're interested in a lumpectomy, they need to see a radiation oncologist. If they're interested in a mastectomy, we want them to see a plastic and reconstructive surgeon so they can likely have immediate reconstruction. So it's a team approach, which sort of gives people second and third opinions right up front, and gives them a chance to hear all this stuff again, because it's all new, it's frightening, and it's really helpful sometimes to hear it from different perspectives. Once a woman's diagnosed with breast cancer, we proceed first with an MRI to try to see how extensive the tumor is. And second, we get the patient to see a medical oncologist. It's important to have a multidisciplinary approach, and they can hear from more than just the surgeon what their options are. I think it's really important to have a full understanding of what's involved with breast cancer. I a lot of times tell the story of the blind men that were asked to describe what an elephant looks like, and everybody has their own perspective. One blind man grabbed the trunk and said it's like a snake, another grabs the tail and says it's like a rope, another grabs the leg and says it's like a tree trunk, and one touches the side and says no, it's like a wall. We doctors are kind of like that. We have our own perspective, and a surgeon hones in on the surgical perspective. I know a lot about medical and radiation oncology, but I know mostly about surgery. So it's really important, I think, for each breast cancer patient to see a medical oncologist to get that extra perspective, and to talk to, if they're interested in having a lumpectomy and radiation, to talk to a radiation oncologist. I don't want to operate on somebody who's going to need radiation without them having an idea what they're going to get into. They need to also see the plastic surgeon if they're going to have a mastectomy and they're interested in immediate reconstruction, which we strongly encourage. They get a chance to talk to those people. And the idea is to get a chance to get the big picture. It's far more important to do it right than to rush. Breast cancer generally is a very slow-growing cancer. It's far more important for us to do it in a deliberate, regular, standard fashion, so that we can make sure that we don't have to go back and say, gee, if I'd only known that, I'd have done something differently. The woman's decision is independent. It's individual. Every woman's cancer is different, every woman's life is different, and our job is to educate that woman so she can have the best understanding of the treatments that are available and make the best choices that will work for her. If somebody chooses to have a lumpectomy, they'll typically start out in the breast center, where one of the radiologists will numb them up and put some wires around there. These are guide wires to help us localize the tumor to make sure that we have the best chance of getting clear margins. We'll then take the patient to the operating room, and after they're under anesthesia, we'll also inject some numbing medicine, which helps them not hurt as much when they wake up. We'll take the lump out. Radiologists will x-ray the lump before the patient wakes up, so they can make sure that we got what we needed. They're closed with stitches that dissolve. They have tape and glue on the outside, and they generally go home a couple of hours later. We usually recommend that they not go back to work that week, but they probably take that week, the rest of that week and the weekend off, and a lot of times they'll go back to work the following week. A clear margin means that the edges of the lump have no evidence of any tumor. We want to make sure that we haven't left any tumor behind. And if we have tumor on the margins, we have to be concerned that there may be tumor left in the breast, and that would be a margin that's not clear. So we want to make sure we have clear margins all the way around.